infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
And on today's show, I'm going to look at one of my favorite topics, and that's rabies. And I'm really honored to have my two guests today, both returning guests. Now, Pamela Wilson and Dr. Rodney Rohde have teamed up to write a comprehensive look at the aspects of rabies, clinical signs and symptoms, epidemiology, laboratory diagnostics, post-exposure prophylaxis, and even a little bit about rabies myths. The title of the book is Rabies, Clinical Considerations and Exposure Evaluations. Pam Wilson, Dr. Rodney Rohde, welcome back to the show.
Well, hi, Robert. Thanks to you and your listeners for your interest and for sharing this time with us.
You're welcome.
Same here, Robert. It's always great to come back, and it's a privilege and an honor to be on your show. And Pam and I really are excited to share this important information today.
Yeah, and it's a great book. And let me go ahead and start out with Pam. Pam, why this book and why this topic?
Rodney and I had worked with Dr. Allison Burt on the publication of 2 articles on rabies in Elsevier Connect. The first article was published in 2015 in recognition of World Rabies Day, which annually is September 28th. Subsequent to that, we received and continue to receive questions on rabies from readers worldwide, especially pertaining to the range of the incubation period and the modes of transmission. So the three of us felt that with this much interest in our articles, a book featuring these real-life situations and concerns would be beneficial to health professionals who deal with rabies and or should be aware of rabies. But from there, it evolved into preparing a very comprehensive but concise overview of rabies and its many realities and fallacies. So we requested that Dr. Skip Ertley and Rodney Willoughby join us in this project. We were definitely grateful to have them as part of the team and have nothing but the deepest respect for both of them.
Dr. Rohde, you want to piggyback on that?
Sure, thanks. I echo everything. For both of us as longtime zoonotic educators, we've known each other since about 1994 when I worked at the health department at the Texas Department of Health. And so with Pam's background in rabies education and my background in laboratory diagnostics and both of our kind of immersion in this topic, it just seemed like a wonderful opportunity for us to really put something together that, you know, not only clinicians, but even the general public might find very useful. And that's really what we were aiming for in this book. And I'd like to also thank Elsevier also for giving us this opportunity. Our article that was online went viral to thousands and thousands globally. So this was a natural next step for us.
Yeah, and that really leads to my next question. You know, I read the book, obviously, and Dr. Rohde,
there'll be an exam when we're done here.
Yeah. Wonderful. Is this a textbook, a guide, or, I mean, I'm asking because I read it and it was a very leisurely read.
Yeah, I think when we started out, it certainly, I don't think, is a textbook. It could be utilized as perhaps additional information for a course, for instance, but it's really more of a clinical guide because it was obviously written by multiple leaders from all realms. So we've got a physician, we've got a veterinary doctor, and we've got Pam and myself that have different subject matter expertise. And so it's a really very compact type of volume and guide that's giving you up-to-date information and all sorts of recommendations on actual rabies cases. Certainly it includes many questions from the public in one of the chapters. So we believe it's very helpful and useful for medical, veterinary, public health personnel, but even the public with respect to kind of determining the types of steps you might follow if you're considering a rabies exposure, kind of how to assess that situation, and ultimately where you might go for a diagnosis and treatment options. And then just trying to be very upfront with very clear and concise explanations and some great graphics and images that will be there, perhaps, say, in a physician's office or in a veterinary's office or other types of healthcare professionals, that it can be very useful right at their fingertips.
Well, Dr. Rohde, let's go ahead and jump into some of the fundamentals of rabies. It's a virus. What can you tell the public about this virus?
Sure. So rabies is obviously a virus that I think evokes fear in people when they hear the word because of the long time study of it and obviously its high mortality rate. The virus itself belongs to an order. When you look at the taxonomy of viruses in the mononeglovirales, and these are viruses that are non-segmented. They are negative-stranded RNA viruses, and within that group, they have a very interesting, distinct shape, Robert. They're bullet-shaped, which is kind of ironic for rabies because it does kill, and it's classified in the Rhabdoviridae family, and rhabdo means bullet-shaped. There's about 3 genera in that family: the lyssavirus, the ephemerovirus, and vesiculovirus. And rabies belongs to the lyssavirus group. And some of the other groups some of the other viruses you find in that group are Lagos bat, Duvenhog, Macalla, Australian bat virus, and all of those belong in that general genus. It's, as you know, it's kind of diabolical in its nature, and it's kind of gained that reputation really because it creates this kind of interesting behavior change. So when someone is infected with the rabies virus, generally there's an aggressive behavior that occurs, including biting, and that tends to help propagate the virus from animal to animal.
Pam, what are the typical transmission routes?
Well, I just wanted to make a general statement that for purposes of our discussion, the term animal refers to non-human mammals. But to answer the question about the typical transmission routes, rabies usually is spread when saliva containing the virus enters a break in the skin. Now, this is typically through the bite from a rabid animal, although transmission could potentially occur when that infected saliva contacts mucous membrane, say of the eyes, nose, or mouth, or any type of break in the skin.
Now, those are the typical routes. What about the atypical routes?
Well, there are some other conceivable modes of transmission, such as, again, mucous membrane or a break in the skin, having contact with virus-laden tears or neural tissue. And with the neural tissue, that might be through the butchering of a carcass, and the virus-laden neural tissue contacts a break in the skin, or the person gets some on their fingers and rubs their eye, gets it in the mucous membrane. Also, transplantation of corneas, organs, and tissue from an individual with rabies could transmit the virus. Oral transmission potentially could occur. This would be with the consumption of raw meat. This is a concern particularly in areas endemic for rabies in dogs where raw dog meat is consumed. However, cooking will inactivate the rabies virus and resolve that concern. Ingestion of unpasteurized milk from a rabid cow has been considered to be a theoretical route of exposure. More research is needed on that speculation. Nonetheless, the process of pasteurization destroys the rabies virus. And then last, airborne transmission has been reported in at least one laboratory worker and in 2 humans who had been in an unventilated cave with a very dense population of bats. However, the 2 cave cases, they've been in the books for a long time, but the mode of exposure has been brought into question, as it is possible that it was maybe an undetected bat bite or some other direct exposure.
Yeah. Speaking of bats, Dr. Rohde, the CDC just put out a vital signs the other day concerning bats and their special role with rabies in the United States now. Why are bats of special concern concerning transmission?
Robert, in about the past 2 to 3 decades, bat rabies have really become the predominant virus variant in the United States. Our book explains this in several of the chapters, and as you mentioned just recently in that CDC vital signs report, it's now reported that about 7 in 10 rabies deaths among people in the United States were attributed to bats. That makes up 1/3 of rabid animals in this country. So if you do the math, that's about 70% of the rabies deaths in this country attributed to bat rabies. of about 5,000 rabid animals tested in 2017, 32% were bats. And since 2015, bats have actually now surpassed raccoons as the largest source of rabies infections from animals in the United States, and that gap continues to widen. Now, there's numerous factors causing this high rate, including our own successes with curtailing terrestrial rabies in the United States with dog and cat vaccinations, for instance, and also just our overall education about being very careful around terrestrial animals like coyotes and skunks and things like that. You know, we're taught at a very young age to be careful around wildlife, and so that makes sense. But not everyone thinks that way about bats. The other major reason is that bat bites themselves are very hypodermic needle-like, so one may never truly know they were bitten. In fact, most of those cases from bat rabies mortalities over the past 2 or 3 decades in the U.S., and really around the country for that matter, they often are not known until post-mortem, when we go back and kind of do some laboratory diagnostics of the human, and if we have the bat available to kind of link that together. And then, you know, the patient themselves or the individuals may not even think to report it, even with early signs of rabies, to their physician, because they just don't know they were bitten. They didn't recognize it. There was no blood drawn with that little nick of those incisors. And so it's a real kind of vicious problem when you don't understand that you've been exposed, and so therefore you don't report it in your history to the physician.
Yeah, I think you really touched on something there concerning that a lot of people don't realize that bats can be rabid. And I go back to the story of the gentleman who died in November in Utah, and in an interview with his wife, they were saying, you know, they would handle the bats. Bats were in their house. They'd wake up in the morning. Bats would be on the bed. And to me, that's just astounding. But there are people that still believe that, you know, and it's really a low percentage of bats, though, too, right?
It really is. You know, when you look at kind of the overall statistics around bats that have rabies, it's usually reported in like less than 1%. But what people need to understand in the general public and in the healthcare setting is that that's usually a number looking at healthy, you know, living, flying, kind of normal acting bats. When you look at bats that are downed or sick or acting strangely on the ground, that's really where you want to be careful, because in my experience, and just speaking about my experience at the Department of Health when I was working there, our data showed that usually that was more like a 10% figure when you looked at that population of bats that were downed and sick. So even though that's 1 in 10, that is still a very high concern when you have perhaps a child handling a bat on a playground, for instance, and not understanding that.
Yeah. I'm talking to Pamela Wilson and Dr. Rodney Rohde, authors of Rabies, Clinical Considerations and Exposure Evaluations. Pam, there's a lot of misunderstandings when it comes to what's an exposure. Can you shed some light on that, please?
Sure. One common thing is that virus contacting intact skin is not considered to be a mode of transmission. As long as you've got an intact skin barrier, that protects you against acquiring the virus. Also, contact with feces, blood, urine, or skunk spray are not considered to be modes of transmission. Another one that Rodney and I got a lot of questions about was the virus existing on environmental surfaces. Mm-hmm. The lyssaviruses, which rabies is a lyssavirus, they replicate primarily in mammalian tissue, so they don't survive outside the host. And the rabies virus can be destroyed very easily by sunlight, desiccation, excessive heat, things like that. So transmission in the environment is very unlikely unless, for instance, say there was infected saliva that was still very moist and contacted a mucous membrane or a break in the skin. But no cases of rabies have been reported in association with environmental surfaces.
Yeah, and concerning if somebody inadvertently handles or pets a rabid dog or cat, for example, very, very little risk, right? Or no risk.
Right. If they pet a rabid dog, and if they've got intact skin, absolutely no exposure there. The only thing would be is if they had a break in the skin and the animal, they hypersalivate, And if it had a lot of saliva and the person happened to contact that saliva with a break in the skin or contact the saliva and then maybe rub their eyes or nose, or mouth and possibly get it that way.
Yeah.
That's very low risk.
Mm-hmm. Dr. Rohde, any thoughts on that?
No, just I would confirm, as a microbiologist, that is absolutely true. The rabies virus, in fact, many viruses are very susceptible to UV rays from sunlight and desiccation and stuff like that. So that's a great thing about the environment is, we don't have to typically worry about that type of exposure stream.
And rabies is pretty rare in the United States. However, animal rabies is still pretty common. What animals are of most concern for rabies?
Well, in the United States, rabies in wildlife constitutes over 90% of the cases of rabies in animals. The animals with the highest case numbers usually are bats, raccoons, and skunks, but foxes are also routinely included in the list of high-risk animals for rabies. Now, conversely, on a worldwide basis, approximately 99% of human rabies cases are caused by exposure to rabid dogs.
Yeah, and outside this country, I think I read one time that the second most common cause of rabies is monkeys. Can you verify that?
I have not heard that.
Okay, all right.
I haven't heard that either.
Okay.
No?
Yeah.
Wow.
Monkeys can get rabies, but they're kind of in the other category.
Yeah.
They aren't considered high risk. They aren't considered low risk. And a lot of animals are in that they can get rabies, but I wouldn't consider them high risk.
Yeah, and there's other mammals that are essentially low risk or almost no risk, like say mice or squirrels or rabbits.
Exactly.
And why is that?
Well, a lot of the thought on that is, especially with the rodents like rats, mice, squirrels, if they encounter a rabid animal, they probably aren't going to survive the encounter. And there have been a few cases, say, with rabbits getting rabies. And a lot of the examples with these, they are considered very, very low-risk animals, but they were caged outside. And all they can figure out is that a rabid animal started, really trying to bite and attack the rabbit and got to it through the caging, but couldn't get to it enough to kill it, and so it developed rabies.
That makes sense.
Yeah, in my decade of working there, Robert, I tested probably thousands and thousands of different types of animals, not only in Texas but around the country, and even some outside of the U.S. I mean, I can count on my hand the number of times we saw a rabid lagomorph or a squirrel or a rodent. So it's really rare to see that. I would also add that there is some thought in the literature that there may be a difference in the animal biology. For instance, the temperature, the body temperature, things like that. It may not be as conducive to kind of allowing rabies to replicate and things like that.
Yeah.
There was one thing I wanted to mention about opossums. One theory I wrote was that they may be more resistant because they, in the research, the muscle content of the possum has a lower quantity of nicotinic acetylcholine receptors, and these are basically the receptors that the rabies virus binds to. When it crosses that neuromuscular junction, it multiplies in the muscle and then crosses over to the nervous system, compared to like high-risk animals like the fox that, might have a higher. So, ironically, when I was writing the chapter on clinical signs, Texas had a very unusual occurrence with 2 opossums that were laboratory confirmed positive for rabies in 1 year, which was really very rare. They were both from the same county and had the South Central skunk rabies virus variant. But I don't want that to be misleading because even given that uncommon occurrence, opossums are still considered to be very low-risk animals for rabies.
Yeah, and livestock are also, that's a relatively common?
We put those in the kind of other animal category as well, not high risk, not low risk.
Yeah, probably a little more common than rodents and things like that, but certainly not like the high-risk animals.
Pam.
But definitely low risk.
Okay, yeah. Pam, what do you see as far as signs and symptoms when an animal is rabid? And from the time of infection to death, how long is that incubation time?
Okay, well, initially, they may just have very nonspecific signs, like they won't be eating, have fever, vomiting, lethargy, things like that. But the two most common clinical signs that are mentioned are unexplained paralysis and behavior changes. Now, those behavior changes aren't just what are capitalized upon in movies like Cujo, in which the friendly dog becomes aggressive and agitated. It could be like a playful kitten that has become shy and withdrawn. Classic scenarios are a nocturnal animal being active in the daytime, like skunks, raccoons, or bats being out in the daylight, or wild animals losing their fear of people. That's where we, have case investigations where a rabid skunk is found in a dog yard, or a rabid fox is found in a stall with a horse. There's a litany of other clinical signs that an animal may or may not exhibit. For instance, ataxia. The people might describe the animal as staggering, like it was intoxicated. Head pressing or head tilting, that is commonly seen in rabid horses. Chewing at the bite site, they get a tingling sensation at the bite site, and they chew it to the point of possible self-mutilation. In fact, there have been reports of rabid animals actually amputating their own appendages by chewing at the bite site so tenaciously. Difficulty swallowing. Hypersalivation, and a lot of times it's a thick rope-like drool, making choking sounds. Pica, that is where they're eating non-food items like wood or stones. Also, hypersensitivity to stimuli. They are overreacting to sounds, light, and touch. Again, watch Cujo and see how he reacts to the phone ringing. And also altered phonation. In cattle, that might be a repetitive bellowing. Or in dogs, you might get a very high-pitched, distressed howling, like a woo, woo, woo. And I should have put a little word of caution. If there's any dogs in the audience, don't be alarmed. That was done for demonstration.
Hey, I am impressed with your dog sounds and cow sounds.
That was really well done
for you.
Mm-hmm.
And then you asked about death. Once there are clinical signs, death usually occurs within 7 days, with a range of 1 to 10 days. But with the incubation period, which is the time from exposure to development of clinical signs, a common average one that's cited that's pretty easy to remember is 3 weeks to 3 months. However, it could be days or even years, but rarely exceeds 6 months.
Fascinating. All right, I got about a minute left for the first half. Dr. Rohde, let me go ahead and start the question, but I'm going to have to cut you off in the middle. And it's concerning the incubation period in humans, and it's very wide-ranging from what I see, from days and weeks to months and years. Can you give us a 20-second snapshot before we get to the half?
Absolutely.
Yeah.
Since Pam just described the animal incubation and that it's somewhat similar, but let me kind of just lay it out. For humans, the incubation period is typically generally in the 20 to 60-day range. However, fulminant disease can become symptomatic within 5 to 6 days and kind of more worrisome in 1 to 3% of the cases. So still very few. The incubation period can be up to 6 months or greater. Okay. There have been some confirmed rabies.
Dr. Rohde, I'm going to have to cut you off. We're up against a hard break. And after the break, more with Pamela Wilson and Dr. Rodney Rohde. Well, welcome back to the program. And today's topic is rabies. rabies all the time. And I'm talking to Pamela Wilson, Dr. Rodney Rohde. They are the authors of Rabies, Clinical Considerations and Exposure Evaluations. And Dr. Rohde, I want to go ahead and pick up on the topic we were talking about before the half concerning the wide-ranging incubation period for humans. Can you go ahead and pick up on that?
Sure. So we'd kind of mentioned that it's generally 20 to 60 days, but sometimes that can be a much longer period and a lower number of cases. There have been some confirmed rabies cases in humans occurring as long as 7 years after the exposure. There's really not a lot of great research data to kind of discriminate why that long latency is known. So it could be a variety of factors from where you're bitten to the amount of virus that perhaps entered into the bite or into the site, but there's truly no real hard data to kind of understand why it might be that long of an exposure. Fortunately, it's typically more, or unfortunately, but typically it's more in a shorter term range that we kind of know what's happening. Right.
Now, something I found really interesting is the time the virus takes to travel the nerves to the brain. It goes in little, millimeters, centimeters. I don't know what it does, but it's not a very long travel per day. Dr. Rohde, can you explain how this works?
Sure. Just kind of to review, remember that rabies is a virus. It's a viral zoonosis, and it affects the central nervous system of warm-blooded animals. And that transmission typically occurs when saliva that contains the rabies virus is introduced into that opening in the skin, perhaps, or via the bite of a rabid animal. And as Pam mentioned earlier, even though it's rare, you may even get that kind of entry of the virus through infected saliva containing mucous membranes or a scratch or break in the skin. But basically, what's known is that after the actual rabies virus enters the body at a bite site, for example, it will begin to multiply in the area near the entry site. So that actually links later to why we might do post-exposure with rabies immune globulin in the bite site to try to neutralize that virus right there. Regardless, if that infection is not stopped at that area of the bite or the entry point, the virus will eventually invade those surrounding nerve cells in that area. And then the virus, once it's in that nerve tissue, it will travel along that nerve system to the brain. And then that will allow it to multiply in the brain itself. And then actually the virus will then spread along the nerves from the brain to the salivary glands or even to other parts of the body. For example, after it reaches the brain, the virus has actually been found in organs that have been donated. So it can actually go back out of the brain into other organs and unfortunately end up in something like the kidney or the ureters of the kidney. It's also been transmitted via corneal implants, as we've mentioned before. Mm-hmm. Again, fortunately, those are rare instances, but it does give you pause sometimes to think about other parts of the body that might actually harbor rabies virus.
Yeah, so because of the time of travel of the virus, a bite to the lower leg would be less of a, stat procedure as opposed to a head or face bite.
Yeah, I mean, in general. Yeah, in general. So like if you were bitten on the small toe of the foot, just kind of common sense would tell you that that's going to take a little longer, and you would have maybe more time before symptoms showed, things like that. So as long as you had the history there and you know what was going on, you could go ahead and start treatment and so forth. Certainly a bite to the face or neck or, close to that part of the body is going to be a very more kind of grave concern.
Yeah. Pam, as I mentioned earlier, human rabies is quite rare in this country, but not so elsewhere, huh?
Oh, you're correct. In the U.S., there's usually 1 to 3 cases of rabies in humans reported annually. But globally, rabies remains a very devastating disease of public health significance. Rabies or rabies-related viruses exist in every continent except Antarctica. And it's really difficult to assess the number of human rabies deaths worldwide due to underreporting in developing countries. But there are approximations reaching 59,000 cases per year or higher. The estimation is that more than 99% of rabies case fatalities occur in developing countries, particularly Africa and Asia, with India accounting for the most reported deaths in Asia.
Yeah. Is there any U.S. states that are rabies-free?
Hawaii.
Yeah. Dr. Rohde, rabies is broken down geographically by the animal or the virus variant. Can you explain to the audience what all that means?
Certainly. One quick point, though, about Hawaii that just kind of popped in my head is It's interesting that if you're in the States or another country, and Pam may mention this later, too, if you're traveling from a rabies endemic state or country to a non-rabid area like Hawaii, there are all sorts of lovely quarantines and kind of public health laws you have to follow because they certainly don't want to introduce that into their animal population.
Right.
But with respect to the animal or the different variants, the rabies virus itself is really a complex of different variants. So different. Sometimes people like to use the word strains, so kind of different types of rabies. But the virus itself typically remains sequestered in a particular animal reservoir because it will adapt to that animal. Due to that feature, rabies virus variants are often discussed in terms of, for instance, canine rabies, or, for instance, skunk rabies, or raccoon rabies, or even bat rabies. However, having said that, even though we kind of think of that reservoir in a particular animal, the virus can have and does spill over to other animals. For example, a skunk rabies virus variant, so a skunk virus, can spill over to a dog when that skunk with that variant interacts with the dog and bites it, for example, and transmits it to the dog. And then that dog, which is a canine, would exhibit all the classical signs of rabies, but with a lab test, you could type it as a skunk rabies strain, if that makes sense. So a dog would have skunk rabies, and that's been shown across almost all variants. Back in 2001, as I was kind of wrapping up my time with the Department of Health Rabies Laboratory and the Zoonosis Control Division, I had an interesting opportunity due to doing some regional typing from around the country. And we got an opportunity to document the first evidence of a bat rabies variant being transmitted serially, in other words, from one animal to the next in an Arizona skunk population. And that was the first documentation of that in the literature. And that's just one example. We certainly see that spillover across all types of mammals with respect to rabies. Likewise, we often can see a particular variant like the raccoon rabies variant found in one part of the country. So for the raccoon variant, we typically see that in the northeastern United States. And that can be due to a number of factors like geography. The raccoons can't get over a mountain range, or their actual range of travel is very small. Of course, all things can happen. Those animals can be translocated to other states. Pam and I have seen that many times, even with things like hunting clubs, where they'll trap different types of animals, including coyotes and fox and things like that, and transport them to like Alabama, for example, and suddenly you've moved a rabies virus into a naive population where it can take off. So those are always kind of sad and scary. And then we've got the whole problem with bats. They are not, held down. They are very mobile because they can fly. And so that whole diverse genotype of bat variants can cross all sorts of geography.
Yeah. Do you know the animal or the virus variant in Puerto Rico?
Pam, isn't that
there's a lot of mongoose.
Mongoose, yeah.
In fact, mongoose is very prevalent in Puerto Rico. And so that's where I also wanted to mention, when you were mentioning about monkeys and primates, that's where when you're evaluating an exposure, you would look at things a little differently with a monkey bite, maybe from someone's pet monkey in the United States. Yes, they can still have possibly rabies, but a little different if they're a monkey bite from a wild monkey where rabies is endemic.
Sure.
Absolutely. The other quick comment about that, Pam, is that certainly when you're traveling, a really important point from our interview today is if you're traveling outside of the United States, and of course in the U.S., but if you're traveling to rabies endemic countries where there are high rates of rabies, you really want to understand, your interaction with even dogs, because feral dogs in places like Asia and Africa are a much different situation versus your backyard in Texas, for instance.
Yeah, and we can look at the most recent case out of Virginia, right? Right. That lady went over to India and played with a puppy or something, and that was a wrap.
Correct.
Very unfortunate. Yeah, I mean, but it's just amazing that people don't think about that, and I think that's pretty much what the CDC was trying to achieve with the vital signs. Is you got to stay away from these creatures, and
just constant reminders for travelers, because we get we're very fortunate and blessed in the U.S. to not deal with dog rabies as much as we used to, but traveling is a whole different game.
Yeah. Well, I'm talking to Pamela Wilson and Dr. Rodney Rohde. They are the authors of Rabies: Clinical Considerations and Exposure Evaluations. Pam, dog rabies, and we've touched on this a lot already, but this is what I grew up on, right? But it's been eliminated from the United States. How exactly did they do that?
Well, I think most of the credit goes to campaigns involving pre-exposure rabies vaccination of dogs. Yeah. Also control of stray dogs, but a lot of that campaign was in the 1940s and 50s, really reduced the number of rabies cases in dogs in the U.S., and of course, it's helped that we've got very progressive animal control programs. We've now got educated animal control officers, enactment of leash laws, and I also think an emphasis on sterilization of pets to reduce overpopulation. So yes, that with all of that going on, the transition went from dog rabies in the U.S. to, as Rodney's already mentioned, bats.
Yeah, I saw an interesting story recently where, and this is, I don't know what their technical job is, but somebody with the U.S. government, they were banning dogs coming over from Egypt because of rabies, and that was a very recent thing. So, I mean, there's somebody out there monitoring these animals coming into this country.
Correct, and that was because of a few rabid animals coming from there, and then you have to deal with all the exposures along the way, and so they decided, we need to put a ban in place for a while.
Yeah. Pam, can you go ahead and talk about the typical health department protocol for handling a rabies exposure? How does that work?
Well, sure. If you have an animal that's laboratory confirmed positive for rabies, a case investigation is conducted. That can be either by health department personnel or animal control personnel, or the local rabies control authority for an area. And they determine during the investigation if there are any people or domestic animals potentially exposed to that rabid animal. And advice is given, of course, on contacting a physician or a veterinarian for the animals, the exposed animals, as they are the healthcare professionals who ultimately decide if rabies post-exposure prophylaxis, or PEP, is warranted, and they also are the ones that would prescribe the rabies biologics if it is. But health department personnel are equipped to provide guidance on risk assessments, such as the prevalence of rabies cases in a given area, what constitutes an exposure, and the protocol for administration of rabies biologics. And I know our regional personnel in zoonosis control do a tremendous, phenomenal job of those risk assessments.
Now, Dr. Rohde, let's talk about diagnostics a little bit now.
Yes, sir. Let's get into it.
Yeah. don't get too excited.
The lab geek is ready to go.
Yeah. Diagnostic rabies testing on animals is really critical, essentially, for making life and death decisions. What's the general process?
Sure. So basically the process is that after an animal has succumbed to the virus and died, or some other means that the animal has been submitted for testing, a necropsy is performed by the proper professionals, and the brain is obtained. So you ultimately want brain tissue. In that post-mortem process, there's really three areas of the brains that are tested: the brain stem, if they're available, the brain stem, the hippocampus, and the cerebellum. The gold standard for post-mortem rabies testing has always, or at least in the last several decades, has been the Fluorescent Antibody Test. The three brain parts that I just mentioned are utilized to create very thin smears on a glass slide, typically. And then that slide is flooded, after it's fixed, is flooded with fluorescent-labeled rabies antibody. if the brain has rabies antigen, and antigen is a term for viral proteins, the antibody will bind to the antigen. So for our audience that may not be familiar with this, I want you to think about a lock and a key fit. So if there is rabies protein in that brain tissue, the rabies antibody will fit it like a key. So it's a very strong fit. It's very specific, and that antibody will not be washed away during the process. Once that process is finished after an incubation, those slides are taken to a dark room, and you examine them under a UV microscope. And if that positive smear exhibits a starry kind of apple green fluorescence, then that lock and key fit occurred, and you end up with a positive test. If the rabies virus was not in the brain, then there wouldn't have been any rabies antigen for that antibody to kind of lock onto, and so the antibody would be washed away, and you still look at that slide, but then it would appear very dark or certainly no green fluorescence, which is indication of a negative test. So this fluorescent antibody test and these procedures are very long used. They're the gold standard, and it really approaches 100% sensitivity and specificity. Of course, and it's really unfortunate, this is primarily a post-mortem test, meaning the animal, obviously is going to be dead.
Yeah, and so they're doing the DFA testing, but there's new testing being developed. We're looking at PCR and some other techniques. Dr. Rohde, what's the future of rabies testing?
Yeah, absolutely, Robert. That DFA has, been a long-standing, wonderful test with respect to time and cost and validity. So I think it's going to be around for the immediate future, and probably going forward is even as the test you're still going to rely on. However, the polymerase chain reaction, PCR, as you mentioned, and even other really powerful molecular diagnostic testing. So again, for our audience, that means you're looking now at the nucleic acid. You're searching for the RNA versus viral protein. That's been used really now for about 30 years or so, I would guess, for rabies. When I was at the Department of Health rabies lab, I actually had the opportunity to travel to the Centers for Disease Control in 93, 94, and helped kind of develop this testing for animals for rabies. And it's really very useful in that it can pick up very weak kind of positive infections. So that's kind of the beauty of a polymerase chain reaction, is that it will amplify the rabies RNA to numbers to where you can then detect it with different platforms. That test, those types of tests, can be utilized to type. In other words, type those variants we talked about earlier. So that's kind of a nice feature. You can determine if it's raccoon or bat or what have you. And it kind of helps you piece the story of an infection together. In some instances, one can even, if you get the proper collection of brain tissue or saliva and even other samples, for example, hair roots at the very base of the neck, you can utilize these nucleic acid amplification tests to actually perform ante-mortem testing, so prior to death. However, let me emphasize that ante-mortem testing must be analyzed very carefully under the proper conditions, and you still have to be in consideration due to the neurotropic behavior. The virus may be absent in the saliva, for example, during the collection. So you have to kind of look at multiple collections, might be necessary at different times. And even then, you want to be very careful of a diagnosis of a negative, because you still potentially could miss that type of infection due to that viral behavior. There's a very new test, Robert, that's just come out. We talk about it in the laboratory diagnostics chapter of our book. It's actually several publications about it as well. It's called the LN34 PAN, P-A-N, lyssavirus, real-time RT-PCR assay. So that's a mouthful.
Right.
But the beauty of this, it's still a postmortem test, but it's very useful in the sense that it represents a really strong candidate for rabies postmortem diagnostics due to its ability to detect RNA across a diverse lyssavirus genus. That's why it's called the LN34. It's very high sensitivity. It's got great potential. You can use it with deteriorated tissues. I didn't really talk about with the DFA. If you have decomposed or deteriorating tissue, that can give you some false negatives and false positives. So this is a much more powerful test in that you can work with those types of tissues. And it's pretty simple to design. So it kind of allows one to test for a variety of those rabies virus variants at the same time with lesser quality tissue. And if we do this enough, like with higher volume testing over time, it may become even cheaper to utilize. But for now, I think we're going to have to watch very carefully. Different labs around the world are validating the testing to see if it might one day replace that gold standard. But in my personal opinion, I think we'll be utilizing that DFA for quite some time.
Yeah, I agree with you. Got about 3 minutes left, and I want to make sure we go over this most important topic, and that's post-exposure prophylaxis. Pam, what do people need to know about that PEP?
Well, with PEP, if it's administered before the rabies virus enters the nervous system, so that would be prior to onset of clinical signs, the disease can't be prevented. But that mode of prevention requires the person exposed to the virus knows to seek medical attention, and the attending physician or veterinarian knows to prescribe the proper course of rabies biologics. The most important thing, though, I want to mention is that if a bite does occur, wash the bite wound immediately with soap and water. Plus a virucidal agent such as povidone iodine is available, and the person's not allergic. But washing the wound thoroughly with soap and water is one of the most effective ways to avoid infection with the rabies virus. But even doing that, you need to promptly seek medical attention and guidance about getting PEP. Rabies is a medical urgency, not emergency, but the sooner you begin PEP, the better chance it has of being effective. So preferably usually within about 72 hours. To subside any fears, PEP is no longer that much feared extensive series of vaccinations. In the U.S., it's a dose of human rabies immune globulin, administered as much as possible near the bite site, and then a series of 4 vaccinations, 5 for immunocompromised people, in the deltoid area. Over a 2-week period, 4-week if they get that 5th vaccination. And the dose of human rabies immune globulin, or HRIG, is just administered at the beginning of PEP. It's based on the weight of the patient. Also, the physician may decide to prescribe antibiotics and tetanus prophylaxis depending on the nature of the bite. PEP is highly effective if administered correctly and in a timely fashion. I also wanted to mention that PEP for exposed animals could also be prescribed and administered. That would be by a veterinarian. It has a little controversy associated with it because it would be extra label use of vaccine. There are currently no USDA licensed biologics for PEP of vaccinated domestic animals. So some states do not allow PEP. Some follow the recommendations of the National Association of State Public Health Veterinarians, which is located in the Compendium of Animal Rabies Prevention and Control. But some states, like Texas, have instituted their own PEP protocols. I'm a staunch supporter of PEP in animals, personally. But a veterinary practitioner should always check for local requirements.
Perfect. And the book, again, is called Rabies, Clinical Considerations and Exposure Evaluations by Pamela Wilson and Dr. Rodney Rohde. And I'll link to it in the show notes when I publish the podcast. And I want to thank you, Pam Wilson, Rodney Rohde, and congrats on the book.
Thank you so much, Robert. And Rodney, always good working with you.
Thank you very much, Robert. We appreciate the time.
You bet. All right. Well, that's the end of the show, and I'll see you next week on Outbreak News This Week. Good day, and God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, OutbreakNewsToday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.